Hey guys, my name is Abhishek. With the NEET PG examination in less than 2 weeks' time, time is precious right now. Time is gold for all of you guys. So, in a bit to contribute, what I've done is that in a single video, I've tried to discuss all of the pediatrics questions in the last 4 years, 2021, 22, 23, and 24, in a single video, and I've discussed the questions. Superficially, not in great depth. So the purpose of this video is that you get all of the questions asked in the last 4 years. Around 55 questions I've got, and in a single video, and also that while revising, you can know that these are the overlap topics and these are the topics which I have to revise from pediatrics alone. So I hope this video is helpful to you guys, and thank you. So let's start the recall. My target for this recall is to aim for both accuracy as well as speed. Okay, so let's start with the first chapter, neonatology in pediatrics. Okay, so the first question: a neonate has not passed urine in the last 24 hours since birth. Next step: continue breastfeeding and observe. Admit to an ICU. Start formula feeds and start IV fluids. Okay, the first thing is that in 90% of the cases, the urine is passed within the first 24 hours. Okay, 99% the urine is passed within the first 48 hours. So, what's the time given? 24 hours. Should we panic? No. What do we do? Continue the breastfeeding and observe. Okay. Should we admit to an ICU? Yes. But when? When the urine is not passed and more than 48 hours have elapsed, or after day 1, the urine output is less than 1 ml per kg per hour. Okay. What is the fluid challenge? It's a homework for you. If you want detailed videos, I can upload videos based on each concepts, but that is if time permits. Okay, so the next is a image-based question, frequently asked 2021, 2024. This was the image which is given. What is it? It is bladder extrophy. Okay, I have marked the other options as well and provided images for the same. What is this? Patent vitalointestinal duct. Okay, same question was asked in 2024 as well. This on phalloceal. As you can see, the gastric contents are covered with the sac. This is gastroschisis. No sac covering the gastric contents. A few words about bladder extrophy. It is also known as ectopia vesicae. The male to female ratio is 2:1. The pubic rami is wide, and that leads to a broad-based gait. Associated with, yes, epispadias, also cryptorchidism. The chances of bladder cancer increases. What type of cancer is adenocarcinoma? So I've just written few words, few clinchers which are important and which can help you in clinching the diagnosis of the questions. Okay. Next question: 34-week pregnant woman, polyhydramnios. We have given indomethacin. Okay, what can be the effect of drugs like indomethacin or ibuprofen or even paracetamol for that matter? In this case, the consequence is that it can lead to a premature closure of ductus arteriosus. If you want detailed videos on these topics, please give a comment on the comment box. Okay. We should also know what's the role of PGE1 in the NICU setting. Okay. So, again, question 4, frequently asked topic, 2021, 2023. Okay. First, figure of 8, snowman, bread loaf, all TAPVC. Second question, figure of 3 sign, notching of ribs, coarctation of aorta. Okay. And this one, egg on side appearance, TG, transposition of plate arteries. Okay. To save time, I have marked the questions for you. Tetralogy fella. Okay. Okay. If you miss these questions, your rank gets thrown back by around 1,000, 2,000 ranks. So please don't miss these, and practice is a must. Okay. Vessel carrying deoxygenated blood back to the placenta. Okay. Umbilical artery. Please don't mark umbilical vein. Please don't mark umbilical vein. Again, fetal circulation needs detailed discussion. If you want a video based on that, please write on the comment section. Okay, this question is more of a practical question, doesn't test your knowledge as such, but it does test that if a baby with hydrocephalus has a VP shunt in situ, develops meningitis. It's a very common complication. But in this case, you will send blood CS, yes. You'll also have CSF culture sensitivity, but you'll not put the baby again. You'll just send the sample via the shunt. Okay, so more of a practical question, but doesn't test your theory as such, does test your practical senses. Okay, 7th question, newborn with RDS, respiratory distress syndrome. Okay, frequently asked topic, a very simple question. The answer is lecithin. This is the most common form of surfactant which is available. You also have common questions like lecithin and sphingomyelin ratio, okay, and also the number of legs which are available. Okay, so these are old tests, but still questions can be asked from them. Okay, next question. Again, unit 3-month-old baby, jaundice, clay colored stools. Okay, we have conjugated hyperbilirubinemia. So the examiner has done one thing easy for you. He has ruled out cricolinazole because cricolinazole is unconjugated. Okay, amongst the remaining options, Dubin Johnson, rotor, and biliary atresia, we have to choose amongst the 3, right? But the next part, biopsy shows periductal proliferation and fibrosis, and so in this case, the winner is biliary atresia. Few words about extrahepatic biliary atresia. The hepatic architecture is usually normal. Giant cells can be present. In the portal system, there will be marked fibrosis and also some lymphocytic infiltration. Okay, even the peridactylar proliferation can be marked. So if the biopsy findings are mentioned to you, the your life gets a bit easier. But if the histology picture is given to you, I was very weak in histology. Okay, so that can be make your life a bit difficult. But if these findings are mentioned, you can clearly go ahead and mark extrahepatic biliary atresia, which is a close degree of EHBA is neonatal hepatitis. So please compare and contrast the two conditions. Okay, again, newborn, incorrect. Can we clearize its swell swab? Yes, we can. Can we start AVF as early as possible? Yes, we can. So what's the wrong answer? The wrong answer is bath the baby with warm water. Nowhere it suggests that you can bath the baby with warm water. Bathing is allowed, but that is post-discharge, not immediately. When the newborn is just born, after within 24 to 48 hours, you can clean the baby with a clean cloth and just do sponging. Sponging is allowed. Bathing with warm water is not actually recommended. So, a very famous question. 6-week-old baby, repeated vomiting, shows antral nipple sign, sorry for the typo, and also target sign on USG. What is this? This is congenital hypertrophic pyloric stenosis. Okay, in the second session of the exam, there was a single bubble appearance on X-ray. So X-ray in one session, USG in another session, but the diagnosis in both the cases is CHPS, congenital hypertrophic pyloric stenosis. When the mothers are a bit intelligent, they can also give you a hint that they can notice a mass moving from the left side to the right side. Okay, again, 5-star topic. What is the metabolic finding? In some cases, you can find hypokalemic, hypochloremic, metabolic alkalosis, and in later stages, paradoxical aciduria as well. So, surgery, pediatrics, medicine overlap question. This is the USG finding. This is the antral nipple sign. This is something you can clearly see. Okay, and this was the X-ray which was given. Single bubble sign. Diagnosis CHPS. 5-star topic. Okay, again 5-star topic. Investigation choice in posterior urethral valve. Okay, what do? We do micturating cystoerythrography or voiding cystoerythrography. USG shows keyhole sign. This is the USG photo. Okay, POV. Next, earliest time for surgery in cleft lip, 3 months, 3 to 6 months, but 3 months. If they ask for palate, it's 6 to 9 months. Okay. Next, maximum brain growth occurs in the first year. What is this? This is the Scammons growth curve. We have another question based on this. Just follow the solid red line. You can see maximum growth in the first year. Okay. Congenital diaphragmatic hernia. Again, a 5-star topic. What can you see? What are the signs? You can see that the heart sounds are more audible on the right side of the heart. You can also see, you can also auscultate that you can hear gurgling sounds in the chest, and also sometimes a boat-shaped abdomen, right abdomen will be mentioned to you. Sometimes the examiner makes things easy for you, but just by mentioning the diagnosis directly. Okay. In this case, what's the most common site? It is posterolateral. Okay. Okay, so topic 2, speed and accuracy. Okay, topic 2, infectious disease. Very important in terms of pediatrics. Okay, 2-month-old infant of HIV positive mother, loose stools. So what do we do next? Can giardia be the cause? Yes, but is it the most common cause? Not really. Can we test for antibody? Actually, most of the antibodies are passed to the baby from the mother. So again, false positive. We cannot do that. What do? We do dried spot sample for HIV PCR. Okay, again, the diagnosis of HIV in infants is a separate modality. So if you want a video on that, please comment. Okay, vaccine contraindicated in immunodeficiency scenario, live vaccines. Please make a list of live vaccines, killed vaccines, and what are the sub-unit vaccines. Very, very important. Okay, vaccine which can be given to a 10-year-old boy. BCG, limit is 1 year. Rabies, special scenario. Pre-exposure, post-exposure. What do? We give TD. Typhoid can we give? We can give. But what do we actually give? TD. Okay. Child with HIV presents with features of pneumonia. Causative organism. In HIV, there's 3 stages: stage 1, 2, 3, 4. Stage 4 is something which is frequently asked. So, what is a common organism? Pneumocystis. Can MTB cause it? Yes. Will the X-ray picture help us differentiate? Sometimes. But if the X-ray picture is really a bad quality picture, it will make life difficult for you. Okay. But pneumocystis is a common organism. HIV defining diseases. Very, very important topic. Okay. Next. Child, myotonic jerks. Okay. Decreased school performance. Fine. There's history of fever at 1 year of age with rash. EEG shows burst suppression. So life is a bit simple. Life is easier now. What do we suspect? We suspect SSPE. Okay. So this is a background of measles. It is presented to you with SSPE. What do? Measles IgG. This is the EEG pattern. Okay. Now again, infectious disease. Child has fever. Child has rash from face to behind the ears. Complex spot mentioned. Oh wow, complex spot mentioned. Life is easy again. Measles. This is the photo. Can it be white? Can it be grey? It can be both white or grey. Described as grains of sand. Fine. Where is it found? Buccal mucosa, behind the second molar. The rash can appear after the complex spot has appeared. That is on day 4. What is the type of the rash? It is maculopapular. One-liners. Very, very important. Very, very, very important. Again, 3-month-old baby, deafness, vision defects. Again, we're not going anywhere. But now, patent ductus arteriosus. What is this? This is rubella. CRS, congenital rubella syndrome. Okay. Infant with hepatosplenomegaly, thrombocytopenia. Again, non-specific. Now, periventricular calcification. This is suggestive of CMV. So you have to look for the keywords. You have to look for the words which are suggestive of a diagnosis. Okay. Again, cytomegalovirus. Drug of choice: ganciclovir or valganciclovir. Okay. This is the periventricular calcification. Again, respiratory stress, biphasic stridor. Child has previous history of URI. Fine. What is the image showing? Steeple sign. Steeple is the monument, the top part of the monument, which is like a steeple. So this is acute laryngotracheobronchitis. So this is an ENT and pediatric overlap topic. Okay. So again, steeple sign. Okay. So 3-week-old child, very young child, paroxysm of cough, which is suggestive of a whoop, maybe. Apnea is a confusion in this question. TLC is raised. Fine. So if this is pertussis, this is not clearly indicating towards pertussis, but somewhere in Nelson it is mentioned that apnea is a prominent feature when pertussis occurs in very young children. Like in this case, the child is just 3 weeks old. So my best case would be azithromycin. Okay, so this is a case scenario. Unimmunized child comes to you, OPD, white membrane on the throat. Diphtheria is ringing inside our heads, right? Okay, what is the first step? Okay, so if the brother is here who is immunized, what do we give? Diphtheria antitoxin. Okay, same exam, second session, the question was a 2-year-old brother comes whose vaccination is up to date. Fine, 2 years old, 5 years old. What do we do now? We give penicillin. Okay, so these are the keywords. All household contacts are closely monitored for illness for 7 days. What is something which we give to all, irrespective of immunizing status? It is benzathine penicillin, single injection to all. Okay, and diphtheria toxoid can also be given, but to which individuals? Who have not received a booster within 5 years. So, in these 2 case scenarios, what we have to do is that we have to see that who is the immunized brother? 2-year-old child, so penicillin for both. But if the brother is not immunized and the vaccination is not up to date, what do we give? Diphtheria antitoxin. Okay. See, the recalls are not perfectly framed because obviously it's collected from students, but the more of the story is the same, that this is the protocol for contacts of diphtheria. Okay, fine. Now, Again, child presents with intracranial diffuse calcifications. Previous question was periventricular calcification. This is diffuse calcification. Chorioretinitis, hydrocephalus. What do we think of? We think of toxoplasma. What is a triad? Chorioretinitis, hydrocephalus, intracranial calcifications. So that's why I've tried to organize the questions chapter wise. So because when you revise this video or when you revise the chapters again, you know that what questions have been asked from these chapters in the last 4 years. Okay, so it's just a compilation which is helpful for you when you revise the chapters. You'll focus on what is the keyword and what is the things you should focus on while revision. Okay, let's go to the third topic, which is general pediatrics. Okay, acute onset breathing difficulty, 2-year-old child. There is no fever prodrome, no prolonged illness. This is an acute onset illness. So, unilateral hyperinflation on X-ray. Okay, so what can be the options? Removal done by rigid bronchoscopy, correct. Partial obstruction will cause a ball valve mechanism, correct, which can cause hyperinflation, correct. Focal hyperinflated area with no decreased breath sounds will be suggestive of foreign body aspiration. So, what is the wrong option? Child has acute laryngeal bronchitis is a wrong option. What do we know? Removal is done by rigid bronchoscopy, correct. Partial obstruction can cause hyperinflation, correct. Ball valve mechanism, correct. And then focal hyperinflated area with a no or decreased breath sounds can cause is suggestive of foreign body aspiration. Fine. This is the question that was asked FBA syllabus. Okay. Answerometry again, very important. Okay. In this question, 4-year-old child. Height for age is less than 2 SD, but it's not mentioned whether it's less than 3 SD or not. The hint is that if the height for age is between -2 to -3, it's stunting, or 85 to 89% of expected is stunting, or if it's below -3 then it's severe stunting, or below 85% severe stunting. What is mentioned? -2. So what is it? Chronic undernutrition. Okay. Next, 16-month-old boy. 8 kg weight. The growth chart is given. If the growth chart is given, you have to plot it. If it's moderate, -2 to -3, between -2 and -3, then you have to mark moderately malnourishment. Calorie dense food is required. No admission just right now. Okay. Again, 10-year-old child, webbed neck, low posterior hairline, shield-shaped chest, short stature, swollen feet, small uterus, streak gonads. This is a classical feature of Turner syndrome. If you miss these questions, your rank will be thrown back by at least 2000 ranks, because these questions you will not get extra marks for answering them, but you'll be penalized heavily for missing them. Okay, so Turner syndrome, a classical case scenario. The clown scared a boy. This is a mnemonic which all of us used. C for CHD, cystic hygroma, L for lymphedema, O for ovaries, just streak, webbed neck, W. Nipples are widely spaced, N. Okay, S for short stature, SNHL, short 4th metacarpal, A for amenorrhea, B for barbaries are less. This is the diagram which we have made to remember the features of Turner. Okay. Again, anemia, bone pain, hepatosplenomegaly. Till now we are not going anywhere, right? But now bone marrow biopsy shows crumpled tissue paper appearance. So now lots of bells are ringing inside iron, right? This can be Gaucher cells. What is it? Enzyme defect, glucose cerebrosidase. Okay. In the next exam, they can ask you Tay-Sachs disease or von Willebrand disease. Both are important topics. So this is a very important biochemistry and pediatrics overlap. Okay. Similar question asked in 2024 as well. This is the crumpled tissue paper appearance of Gaucher cells. This is growth curve. What's the name? Scammonn's growth curve. See the solid line? This is lymphoid. Between 4 to 8 years, it increases and then it regresses again after 8 years. Look at the dashed line. This is brain and head. Maximum growth at 1 year. Look at the reproductive. Latent till 12 years and then it picks up. And then the overall general growth is a sigmoid curve. So match the following was the question. Okay, again, biochemistry, AGPRT deficiency, self-mutilation behavior. What is it? Leishman-Hand syndrome. Missing these questions, penalty more than merit. Okay, again, pathology plus pediatrics overlap. Achondroplasia is autosomal dominant. Okay, sorry for the typo. Prader-Willi has multiple types. Wilson's is autosomal recessive, and Wiskott-Aldrich was the answer, X-linked recessive. This is a last minute revision topic. Types of inheritance: autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive. These are last minute revision topics. Don't miss this, okay? Again, biochemistry plus pediatrics overlap. Infant presenting with vomiting after feeding. Okay? The genetics test positive for non-reducing substances. Okay, diagnosis galactosemia, which is enzyme defect. There are three enzymes which are defective, but in this case, GAL1 redyl transferase deficiency. Okay, drugs used for ADHD. Methylphenidate can be used, amphetamine can be used, modafinil is not totally approved. The trials have not been successful, but can be used. So the fourth option was a drug. I think drugs used for ADHD, all except was the question. So the fourth option is the wrong option. Okay. Okay, answer 1 again. Infant, birth weight 2.8 kgs. Let's see the correct options. Okay, weight gain of 30 gram per day. Yes, for the first 1 month, it's 30 gram per day. Correct. Antefungal courses by 9 to 18 months. Correct. Length increases by 25 centimeters in a year. Correct. So the fourth option was the wrong option. Okay. Okay, so the slide is filled with images. Let's just see. 10-year-old child, limb pain. Okay. Yes, normal bone density. What do we see? Scorbutic zone. I think it will be a little small for you. Scorbutic zone, dense zone of provisional calcification, also known as white line of Henkel. Ring epiphysis, known as Wimberger's ring. Pelkin's spur, and also subperiosteal hemorrhages. So one, subperiosteal hemorrhage or hematoma. One, scorbutic zone, also known as Stommerfield zone. There is dense zone of provisional calcification, known as white line of Henkel. Number 4, ring epiphysis, known as Wimberger's ring. And 5, Pelkin's spur. If these 5 findings are there, please mark the answer as scurvy. Okay, next. Rickets, going of legs, classical for rickets. Let's see here. What do we have here? We have splaying, fraying, as well as cupping. I've already marked it to save time and for convenience. Bone within bone. What do we see here? This is osteopetrosis. If scurvy has been asked, rickets has been asked, the next year the question can be an osteopetrosis. So that's why discussing the rest of the options is equally important. Okay, metaphyseal dysplasia. Okay, so again, approach to vitamin D deficiency. 6-year-old female. If this is a big topic, consultative topic, if you want a dedicated video on this, please write in the comment box. Multiple courses of vitamin D, but no improvement. So VDDR type 1 ruled out. Again, phosphorus is low. CRF ruled out. What are we left with? Hypophosphatemia rickets. So this is a conceptual topic, requires dedicated video, approach to vitamin D deficiencies. So I'll try to make one before the exam. Systemic pediatrics, last section for today. Okay, 3-year-old child, severe episodes of loose stools, tongue dry, thirst positive. Here's the clincher. Skin pinch goes back very slowly. So this is severe dehydration. This is an LMR topic, types of dehydration. Most common cause is rotavirus, yes. Most common bacteria, Escherichia coli. Most common strain, enterotoxin strain. Management is IVF. Which fluid? Ringoslactate. Okay. 10-year-old child, jerky movement, EEG shows hips arrhythmia. Clincher word, delayed milestones. Okay. What are we dealing with? We're dealing with West syndrome. What can be the drug of choice? ACTH. So discussing West syndrome, there is hips arrhythmia on ECG. There is infantile spasms, jackknife seizures, and also neck alarm spells. This is usually something which is asked in the exam. Also low IQ. So drug of choice is ACTH. Second is vigabatrin, but surprisingly, if tuberous sclerosis is a diagnosis, then vigabatrin becomes the first line. Okay. Next, day 4, TSH more than 100, USG shows ectopic thyroid. What is the next step that we can do? Radiant scan. Again, approach to congenital hypothyroidism needs a dedicated video. It's a long topic, so I'll try to make a video based on this before the exam. So just hold on to that. Again, 11-month-old child, incessant crying, tender mass per abdomen, barium enema shows claw sign. This is the clincher in this question. See the claw sign. What do we have here? Intussusception. Few words on this. Most common at the ileocecal junction. Age 8 to 10 months. Colicky pain, incessant crying. Also, the stools are also known as red currant jelly stools. Okay, mass felt in the right upper quadrant is tender or banana shaped or sausage shaped. USG is a sensitive modality. These are just the key words of the clinchers which will help you in making the or marking the right option in the exam. Again, favorite topic. 10-year-old child, bloating of abdomen, steatorrhea, reduced height and weight. So it's nothing specific right now, right? What we have here is HLA-DQ2 positive. So this makes the diagnosis of celiac disease. What do we mark? Gluten-free diet. Similar question was asked in 2024 also. There the question was, anti-tissue transglutaminase is a positive antibody and used as a screening test. a bit few lines about celiac disease. Gluten hypersensitivity, you know this. HLA-DQ2 and DQ8 is something you know. What do we avoid? We avoid BROW, barley, rye, oats and wheat. It's something we absolutely avoid. This is the gluten-free diet, right? Okay. What is the diagnosis? Small intestine biopsy. What is the best antibody? Anti-inflammation antibody. Okay. Cardiology, infection, my favorite. 11-year-old child, fever 3 weeks back, now at Sergia. So acute rheumatic fever is hanging inside our heads, right? Okay, so penicillin prophylaxis for how long? Okay, so this is given by WHO, secondary prophylaxis. If there is no carditis, no signs of inflammation, then 5 years or 18 years, whichever is longer. If there's carditis on echo, if there's mild MR, then 10 years or 25 years, given by WHO. Or if rheumatic heart disease is established, variable heart disease, or surgery has been done, then lifelong. So in this case, what's the answer? Next 5 years or till 18 years of age. This is the answer of this question. Okay, what drug do we give? Penicillin. Which penicillin? Benzathine penicillin. How much? If the weight is more than 30, then 12 lakh units every 3 weeks. If the weight is lesser, then 6 lakhs, half dose every 2 weeks. Okay, if it is not available, usually it's not available in many centers, then what do we do? Oral penicillin, 250 twice daily. If there is penicillin allergy, then erythromycin, same dose, 250 twice daily. Okay. Another key topic for exams. All of you have passed your final exams, so you might be well aware of this. But edema, sorry for the typo, anasarca, massive proteinuria. What's the answer? MCD is a diagnosis. Answer is good response to steroid. Excellent response to steroid. Okay. Nephrotic syndrome, nothing to teach you. You guys know. You guys passed your final exams. More than 40 keywords. Hypoalbuminemia, yes. Edema, yes. Age is 2 to 6 years, yes. Duration is 12 weeks. Okay. All the glomerulopathies, FSGS, MCD, IgA nephropathy, MPGN. Please read this very carefully. Even nephrotic syndromes, very, very, very important. Okay, 5-year-old child, difficulty in walking, getting from squatting position, muscle biopsy taken. Okay, I'm very bad at biopsies, but death by third decade. Previous history viral prodrome is not present in most cases. This is not a mitochondrial disorder, and the treatment does not have an excellent prognosis. It's a very difficult disease to treat. Okay, causes of death: respiratory failure, intractable heart failure, aspiration, airway obstruction. What are we dealing with? By now you already know. We're dealing with Duchenne's muscular dystrophy. Few lines about this disease. Most common neuromuscular disease, X-linked recessive. Proximal muscle weakness, yes. Gower sign is positive but not low specific. Okay, Gower sign is in a lot of conditions where the proximal muscle is weak. Fine. Pseudohypertrophy of calf, yes. Loss of ambulation is early, yes. Dystrophin gene defect, yes. A few one-liners which are important, which you have to know just to clinch the diagnosis. Okay. Henoch-Schönlein purpura. Rheumatic, palpable purpura, lower limbs, buttocks, sorry for the typo, abdominal pain, joint pain. What is the criteria? Palpable purpura is something which you need. Okay. Along with that, one or more of either abdominal pain or arthritis, arthralgia, or biopsy of the skin showing IgA deposition. So, the dermatologist has to be called, a referral has to be sent to the dermatologist department as well. Renal involvement also important, which can be in the form of proteinuria, hematuria, red cell mass. So, abdominal pain, joint involvement, arthritis, arthralgia, biopsy of skin showing IgA deposition, and renal involvement. Okay. Again, 5-star topic. 9-year-old child, chest infections, we see bulky stool. Okay, stool fat more than 100 grams per day. Okay, what are we dealing with? Cystic fibrosis. What do we see? Distal intestinal obstruction is seen. What is the criteria? 2 elevated sweat chloride. How much? More than 60. 2 cystic fibrosis mutations identified, or 1 abnormal nasal potential difference. Okay, what is our sweat test known as? Pilocarpine iontophoresis. Okay, we're coming towards the end. Again, 12-year-old child, urinary infection, bleeding gums, pancytopenia, serum testing, fat filling globules. This is nothing but aplastic anemia. Okay, again, approach to pancytopenia is a 5-star topic. Patho plus medicine plus pediatrics overlap. If you want a video on this, please comment. Okay, cardiology again. 6-year-old child, hypertension, lower limb pulse, feeble. So extra notching of ribs. Please look in the options for this word, coarctation of aorta. Okay. We've come to the last question. 10-year-old kid, pH 7.01, acidosis, RBS is raised, urine sugar is raised. Okay, so what we're dealing with? We're dealing with diabetic ketoacidosis. hyperglycemia more than 200, venous pH less than 7.3, bicarbonate less than 18, ketonemia or ketonuria present. So what do we do in this case? IV fluids at the rate of 20 ml per kg. After that, we have to give insulin 0.1 ml per kg, 0.1 unit per kg. Okay. So thank you. I tried to summarize all the topics in a short span of time to save your time. We have covered almost all the questions from the last 4 years. When you revise the topics again and again, just try to look for the keywords, look for the clinchers, and I think this will help you in the long run. If you want more videos, please comment, and thank you.